Hi, my name is Professor Atif Darwish, Professor of OBGYN in Asyut University, Egypt. The topic of today is empty follicle syndrome, which is a complaint of many patients when you are attending any clinic of gynecology, particularly infertility clinics. You may find a patient coming to you and says that she had a trial of IVF-XE, but the follicles were empty and no fertilization, no embryo transfer because no oocytes retrieved from her ovaries. What's the solution? What can I do? You should answer her regardless if you are IVF specialist or not, but you are a gynecologist and you have to deal with this case. You should know what's normal. Normally during follicular development, before maturation of the oocytes, the primary oocyte is surrounded by zona pellucida, and this zona pellucida is covered by a layer of granulosa cell, and the granulosa cells form condensation which is called cumulus ovarium, and this condensation is adherent to the basement membrane, and this cumulus oocyte complex is fixed to the basement membrane during the stages of follicular development by cell-to-cell dense or tight junctions, and these junctions prevent the oocyte from floating inside the follicular fluid. But at the time of ovulation, when there is a surge of LH, and this can be mimicked by a bolus of HCG or GnRH agonist, these junctions, cell-to-cell junctions, start to be loose, not tight. So the complex between the oocyte cumulus and the basement membrane starts to separate. So the oocytes are free now inside the follicular fluid. This complex is freely floating inside the follicular fluid, and when we introduce our aspiration needle via sonography, we can aspirate this complex via the needle from the follicular fluid. So at the development stage, the cell-to-cell junctions are very tight, but at the time of ovulation, these tight junctions will become loose and the complex will be free. Moreover, there is a dialogue between the oocytes and cumulus cells. The cumulus cells coordinate oocyte development and maturation, provide energy, substrate for oocyte meiosis resumption, regulate oocyte transcription, and promote nuclear and cytoplasmic maturation of the oocyte. On the other hand, the oocytes regulate cumulus cell function by some agents. So the cumulus and oocytes are not just attached with tight junctions, they enhance the function of each other. At the time of LH surge, naturally or initiated by a bolus of HCG or GnRH agonist, the cumulus cells undergo emulsification with stimulation of detachment of oocyte cumulus complex from the follicular wall, and subsequently there is resumption of meiosis, extrusion of the first polar body, and subsequently ovulation occurs. It's very important at the time of ovulation that FSH increases. Of course, increases in a lower level than LH, but there is FSH surge. This surge is very important to induce LH receptor formation in the luteinized granulosa cells, promotes oocyte nuclear maturation, cumulus expansion, opens the gap junctions between the oocytes and cumulus cells, and the oocyte cumulus cells mass to detach from the follicular wall before ovulation. So FSH is very important. And this is a good point, because when we will discuss the triggering, you will show that the GnRH agonist is advantageous over HCG because it leads to increased FSH, and FSH has a role in ovulation, very important role, not important as LH, but it has a different role. Now, what's empty follicle syndrome? The patient asks you, what's the empty follicles? What does it mean? It means that the doctors failed to get oocytes from your follicles after aspiration, despite adequate ovarian response, despite adequate stimulation protocols, despite meticulous follicular aspiration technique. We did not find any oocytes in your follicles. And this is a syndrome described in 1986. And by this, there is no oocytes in the presence of dominant follicles by monitoring with normal hormonal monitoring and so on. Some authors mention that there is nothing called empty follicle syndrome. Why it is no empty follicle syndrome? Because it seems illogic that one patient has a follicle and this follicle empty. Any follicle should contain the oocyte cumulus complex. This is a mandatory anatomic and physiologic event in any individual. The problem in aspiration, you have to tell the patient that I failed to aspirate the oocyte from your follicle, but the oocyte cumulus complex may be present. I failed to extract it. I failed to aspirate it. I failed to identify it. So it is a syndrome of impaired granulosa cell function in which oocyte meiotic maturation is not resumed, cumulus expansion does not ensure, and the immature oocyte cumulus complex are resistant to follicular aspiration. So it may be a misnomer. Moreover, others mention that the presence of an oocyte is an obligatory event, and a situation of genuine empty follicle syndrome cannot exist. So it's better to say it is not empty follicle syndrome, it is failure of oocyte retrieval. And if you induce the cycles, induce superovulation with perfect drugs suitable for the patient's age and patient's hormonal status, with good drugs correctly administered, the total failure rate to retrieve oocytes is a very rare case, and actually it is a sporadic event as mentioned in many publications. So the occurrence of empty follicle syndrome is criticized by many authors. On the other hand, some authors mention that empty follicle syndrome exists. Why? Because we have many patients with recurrent forms of empty follicle syndrome, despite the change of the induction protocol, change of the center for IVF-XZ, oocyte retrieval timing change, ovulation triggering change, rescue approaches, and so on, and those cases still have empty follicle syndrome. So it is a patient-linked disease. It's not doctor problem, not induction problem. It is the problem in the same patient. And another proof that some patients with, in a case report, a case with unilateral empty follicle syndrome due to ovarian torsion occurring between the time of HCG administration and follicular aspiration. So a case that had ovarian torsion due to ovarian cyst or superovulation, the ovary rotated on itself, and at that time there is HCG administration and aspiration of this ovary revealed no follicle. So the blood supply to the ovary has been impaired. So the problem of the low availability of HCG in the circulation. So it is a problem in the circulation. So we prove that it can occur by this case report. Others described what's called borderline empty follicle syndrome, which means that you induce the cycle with good drugs and you expect to have a lot of follicles, but when aspiration of these follicles occur, you will find few mature and immature oocytes, and this is called borderline empty follicle syndrome, that are retrieved from several mature follicles. and this can be explained by a defect in the process that results in oocyte maturation and cumulus cell expansion. So in conclusion of this debate between these two teams, we have a team mentions that there is nothing called empty follicle syndrome. The other tried to prove, in conclusion, the empty follicle syndrome probably exists. Now what's the incidence of empty follicle syndrome? It may occur in a rare situation if the induction protocol is perfect and if the center is well trained in dealing with different categories of patients. So the incidence may be less than 1% to 3.5% of cases. And the prevalence of empty follicle syndrome, whether false or genuine empty follicle syndrome, is about 5 times higher among patients over 40 years. So the prevalence of empty follicle syndrome increases with increased age of the patient. We have to tell the patients who are old that you are liable to some problems like empty follicle syndrome, poor response, decreased pregnancy rate, and so on. This is very important. In a study on 2,730 cases, the overall incidence was around 3% of cases. What are the predisposing factors for empty follicle syndrome? I told you just now that increased age, increasing the age of the ovary, so ovarian aging is a factor for empty follicle syndrome more than the other patients. Diminished ovarian reserve, prolonged infertility, those will lead to poor responsiveness to gonadotropins, ovarian resistance to ovarian stimulation, obesity, some genetic defects, because many studies found gene problem, gene expression of the granulosa cells from a patient with recurrent empty follicle syndrome was significantly altered compared with control, and these are many studies on the genetic problems of genuine empty follicle syndrome. Can endometriosis be a cause of empty follicle syndrome? Yes, it has been published as a case report that a patient with endometriosis had dysfunction of folliculogenesis and empty follicle syndrome, but it is a case report. Can be a familial or inherited disease? Yes, it has been published in 2 sisters with 3 cycles of empty follicle syndrome. What's the mechanism of empty follicle syndrome? If it does occur, what is the mechanism? The mechanism may be premature ovulation, may be poor ovarian response, low bioavailability of the drugs of HCG, intrinsic defect, dysfunction folliculogenesis, defective granulosa cell function, and mutations in the LH choriogonadotropin receptors. The inadequate preovulatory follicular changes include poor bioavailability of LH or HCG, too short interval before aspiration. If you aspirate the oocytes before 36 hours, this will lead to failure of separation of the oocyte cumulus complex from the basement membrane into follicular fluid. So too short interval may be a mechanism. Premature luteinization, like premature LH surge, high progesterone on the day of HCG, all these can be mechanisms. Others may be dysfunctional folliculogenesis resulted in early atresia of oocytes. Now we have 2 types of empty follicle syndrome. You have to revise yourself. Is this case of empty follicle syndrome is real, is genuine? What's meant by genuine means that failure to retrieve oocytes despite proper ovulation induction, proper drug selection, proper batches, proper patient administration, appropriate normal follicular development, normal steroidogenesis by hormonal profile, optimal beta HCG level on the day of oocyte retrieval. Despite all normal conditions, I did not find any oocytes after aspiration of the follicle. This may be due to underlying genetic cause, and this is called original or genuine empty follicle syndrome. But the other cases, when you fail to retrieve oocytes, in the presence of low beta HCG, which means that there is an error in the administration of beta HCG, reduced bioavailability, technical problems, and any drug problem, batch problem. These are called false empty follicle syndrome, which means that these factors are avoidable. If you correct these factors, you will not have false empty follicle syndrome. You will face only very rare cases of genetic, maybe genetic causes of genuine empty follicle syndrome. So the problem of drugs, problem of administration, the problem of protocols, problem of aspiration are called iatrogenic empty follicle syndrome, and in all these cases there is low beta HCG level on the day of ovum pickup, which the cut short should be more than 40 milli international unit per milli. If the cut short is less than this means that there is a problem in the induction protocol or the triggering, and this may be a cause of empty follicle syndrome. We have to tell the patient that you are liable to have empty follicle syndrome before we are going to the OR. So this is very important. False empty follicle syndrome also can occur due to technical problem. While you are doing aspiration, you may make some mistakes, like incomplete aspiration of the follicles, defects in the aspiration system, the pump is not working well, too low aspiration pressure, air leakage in the aspiration tubes, or any other defects in the egg collection system, which may not be identified and resolved during the oocyte retrieval. So we have genuine and we have false empty follicle syndrome. Can we predict empty follicle syndrome? Can we tell the patient that you are liable to have empty follicle syndrome before starting the egg retrieval procedure? There is no way to precisely predict these cases before starting ovulation stimulation. But we have to consider this syndrome during counseling of old cases, because I told you they have old ovaries and poor ovulation and poor functions of the process of folliculogenesis, and they are at high risk of empty follicle syndrome. Also, the patients with decreased ovarian reserve, decreased antimullerian hormone less than 0.5, less than 4 mature follicles on folliculometry, those patients are liable to have empty follicle syndrome. One of the important tools to expect or to predict empty follicle syndrome and poor ovarian response generally is to measure estradiol. On day 3, if the day 3 estradiol is from 30 to 50 picogram per milli, this means that there is expected good response with increased pregnancy rate. On day 5 and day 8, at day 5, if the level is more than 300 picogram, the responder, the patient is fast responder. If it is at day 8 less than 300 picogram, the patient is non-responder. If at day 5 is less than 300 but more than 300 on day 8, the patient is a slow responder. Also, at the day of HCG injection, if the level of estradiol is less than 800 picogram per milli, this means that the patient is low responder. If it is between 800 and 1500, this means that she is average responder. If it is more than 1500 picogram per milli, this means that she is a high responder. So also estradiol is an indirect indicator of the possibility of empty follicle syndrome. So empty follicle syndrome is associated with very low bioavailability of beta HCG and can be predicted by measuring serum beta HCG level 36 hours after HCG injection intramuscularly before the ovum pickup. And this is very important step. You can predict the empty follicle syndrome when you do just beta HCG for this patient. If it is low at that time, this means that she is liable to have empty follicle syndrome. Another trial to predict empty follicle syndrome is to look at the endometrium. If the endometrium looked as a thick endometrium or type 2 endometrial echogenicity in the proliferative phase, this is wrong. In the proliferative phase, endometrium should be hypoechogenic or the trilaminar preovulatory. But if you see it as type 2 endometrial echogenicity, thick endometrium, this means in addition to precocious serum progesterone rise above 1.5 picogram per milli, disappearance of big size follicles or appearance of follicles with irregular shape, asynchronization of the follicles, all these are predictors of empty follicle syndrome because they are signs of premature ovulation, in addition to abnormal levels of E2 as I told you just now. So also you can predict empty follicle syndrome at the time of oocyte retrieval by two simple things you can do and to diagnose and treat empty follicle syndrome. You can do urinary or blood HCG test before starting oocyte retrieval to exclude incorrect HCG timing administration technique. And you may make puncture of the follicles one by one, waiting until the embryologist tells you that he found an oocyte and at least one oocyte before proceeding to puncture the other follicles. So don't be in a hurry when you are aspirating the follicles, and don't complete the procedure in no time because you have to wait what is the answer from the adjacent lab telling you when you are in OR. So now these are the criteria of empty follicle syndrome and what are the possibilities of its occurrence. Now we are confronted with this lady with empty follicle syndrome. How to treat this case? There is no single treatment universally accepted for cases of empty follicle syndrome. The best approach for treating cases of empty follicle syndrome is to make revision. You have to revise the steps of the previous trial, whether at your lab or in another lab. You have to search for a mistake that led to failure of separation of the oocyte cumulus complex from the wall, from the basement membrane to follicular fluid. What may be the cause? It may be the patient herself. You have to ask her about the drug. How did she receive the drug? What was the storage place, and so on. What was the injection technique? More details from the patient about the drugs. Where the drugs stored? Which drugs used? Which induction protocol? Which downregulation protocol? Which is trigger protocol used, and so on. All these should be revised. If you found any problem in these steps, you have to stop and you have to change, and now you got the cause of the previous empty follicle syndrome and you have to correct it, and perhaps you may succeed to have a good case of positive aspiration. But if you did not find any mistake, you have to assess the patient for ovarian reserve, including HMG and her age because of the aged ovary. And if the ovarian reserve is okay, this means that you have to change the protocols previously used in this case. And if the ovarian reserve is poor responders are poor responders. You have to counsel them that you are a poor responder and you are liable to all the problems of poor response. Now we would like to check the patient. You have to ask her about missing injection, wrong drugs. She may receive a wrong drug, HMG instead of HCG, and so on. Wrong injection, missing powder, leakage of the contents, bad derivation of the drugs. Induction protocol, agonist or versus antagonist for downregulation, HMG versus FSH, batch check, HMG versus FSH dose, checks the triggering, poor preservation, bad batch, and dosage. Of course, we have to go in some details in these steps because they are very crucial for correction of what happened in the previous trials. The pituitary regulation, down regulation, is performed in all cases of IVF ICSI for fear of premature luteinization, which means premature surge of LH that leads to rupture of the follicles, and we cannot aspirate these follicles. So we make down regulation, and this down regulation can be made by GnRH agonist or GnRH antagonist. GnRH agonist long protocol is commonly used, which starts in the preceding cycle and continues in the stimulation cycle as well. And there is another protocol which is GnRH antagonist, and this starts on day 6 when the follicle size reach 14 millimeter. You can start GnRH antagonist after stimulation starts from day 2. So these are the two common protocols for induction in most cases, with some exceptions for poor responders and so on. Now the GnRH agonist protocol is preferred as it is stable with low LH and progesterone levels throughout the stimulation phase, suppresses endogenous FSH level leading to follicular cohort, no asynchronization of the follicles. But it is more time consuming, more costly, acute stimulation due to flare-up, profound hypoestrogenemia due to downregulation, and risk of ovarian hyperstimulation syndrome. But it results in increased number of oocyte collection, increased pregnancy rate, possibility of cryopreservation of embryos, and improvement in routine patient treatment schedules. On the other hand, GnRH antagonist protocol is advantageous in being immediate reversible suppression of gonadotropins without initial flare-up. So initiation of IVF treatment in a normal menstrual cycles with endogenous intercycle FSH rise rather than FSH suppression, thus resulting in a significant reduction in the effective dose and shortening the treatment duration and dose and cost as well. The disadvantages of GnRH antagonist protocol is the high intercycle endogenous FSH concentrations, including secondary follicle recruitment and leading to asynchronization of the follicular size. So it is more suitable for IVF cycles carried out in a given period, starting stimulation a patient scheduled for antineoplastic treatment for ovarian cryopreservation. So each protocol has some advantages and disadvantages, but both protocols regarding ovulation, regarding live birth rate, have similar results. Regarding live birth rate has similar results, but ovulation is more with the GnRH agonist. Some authors mentioned, okay, in empty follicle syndrome we have to switch from antagonist to agonist or from agonist to antagonist. We ask the patient, or we look for the report with the patient. She received GnRH antagonist protocol. Okay, I'll start GnRH agonist and vice versa. This has been proved to be ineffective and not recommended. Also, another case report did not find improvement of the state of empty follicle syndrome despite trials with changing the protocols. What about the drugs used for induction of superovulation? The evidence found that there is no difference or very little difference in live birth, multiple pregnancy, clinical pregnancy, or miscarriage rate between urinary derived gonadotropins and recombinant FSH. The quality of evidence was low to very low for the outcomes from recombinant FSH versus urinary gonadotropins and HMG versus FSH, purified FSH. And this is considered a recent recommendation, and this highlights that you should not stress on the type of induction of superovulation rather than searching for a cause of the empty follicle syndrome, because there is no significant difference between different drugs. A very important point in the topic of empty follicle syndrome is to search for the triggering. The triggering is to induction of separation of the oocyte complex from the base membrane into the follicular fluid. This can be achieved, commonly achieved by HCG and sometimes by GnRH agonist, and sometimes we make combination which is called dual triggering. HCG has the same effect of LH with long half-life, so its effect is prolonged up to 6 days after exposure. So this is an advantage and a disadvantage at the same time. It is advantage because it is a good support of luteal phase. It is a disadvantage because it increases the risk of ovarian hyperstimulation. On the other hand, GnRH antagonist is more physiologic because it increases both LH and FSH. And at the beginning, I told you that FSH is important for separation of the oocyte cumulus complex from the base membrane. So the results of triggering by GnRH antagonist are expected to be more than HCG alone because of better egg maturation. Moreover, the duration of action of GnRH antagonist is short, so there is low risk of ovarian hyperstimulation syndrome. Its action is around 34 hours. We can make combination of GnRH and agonist and HCG, which means that you give GnRH agonist 40 hours prior to ovum pickup and HCG added 6 hours later after the dose of GnRH agonist, so it is given 34 hours before ovum pickup, which is dual triggering. So recombinant HCG was used in many studies, also can be used in combination with urinary HCG as a modified protocol, and this is a recent publication for borderline form of empty follicle syndrome. And you know that recombinant HCG is pre-filled and it is ready to use and purified versus the urinary HCG. So he used both the HCG recombinant and urinary 39 hours before ovum pickup to give them a chance to make separation of the tight cell-to-cell junctions. Another protocol of triggering is to prolong the interval between ovulation triggering and ovum pickup. Usually it is between 34 to 36 hours, but these protocols increase the duration up to 39, up to 40 hours in some cases. Longer times expect better results. There is another protocol for triggering which is called rescue protocol for false empty follicle, which means that there is no oocytes aspirated during ovum pickup. You can, and the patient has low HCG less than 10 international units per milli, you can stop collecting oocytes from the other ovary and you give the patient a dose of HCG and make another trial the second day for the second ovary after this bolus dose of HCG to make separation of the oocyte cumulus from the basement membrane, as I told you before. The drawbacks of rescue HCG is the delayed aspiration and delayed transfer, and this may lead to change in the endometrial receptivity, so the implantation rate may be low in this protocol. The cases of true empty follicle syndrome with proper induction, proper downregulation, proper triggering, proper selection of cases, the treatment of such cases is to prolong the follicle exposure to HCG to widen the interval between HCG and oocyte retrieval to allow looseness of the cell-to-cell junction of the granulosa cells and the cumulus oocyte complex, or to use the rescue HCG treatment. Some authors described a practical protocol. Step 1, you have to check proper HCG administration, dose and duration. Step 2, to make pregnancy test in urine. If it is positive, this means that good level of HCG. If it is negative, you have to expect follicle syndrome. Step 3, improve aspiration technique using double lumen needle for the egg collection, and flush each and every follicle. Each and every follicle. This is very important. At least 4 times. Don't flush once, 4 times. Each follicle. Consider each follicle as the only follicle for this lady. So you have to take care of it. Flush it several times, up to 4 times, more than 4 times. And ask the embryologist, did you find any oocytes or not? Flush several times, every and each follicle, at least 4 times, with expectation of finding 1 egg in each follicle. However, if the embryologist does not get any eggs after you have flushed 3 mature follicles, you have to stop the procedure. And so this is a very important improvement in your technique, to use a double flush lumen needle, repeated flushing, one by one, waiting until he tells you that there is an oocyte, at least 3 mature follicles. If no, you have to stop and give the patient an additional HMG injection to support the follicular growth, and do a blood test to measure estrogen, estradiol and HCG levels, and then give the patient another HCG injection and reschedule her 36 hours after this second HCG, aiming at separation of the oocyte complex from the basement membrane. Ultrasound, of course, is very valuable for monitoring such cases. In conclusion, empty follicle syndrome should be put in mind in every case of RT, particularly those who are at risk, poor responders who have decreased ovarian response, old age, obese patients, prolonged infertility, poor response to HMG, FSH, or women with a history of empty follicle syndrome should be counseled for the possibility of its repetition. Differentiation between the true and false empty follicle is your job as a good gynecologist and good infertility specialist, to differentiate between the real and false cases of empty follicle syndrome. You should make prevention of false empty follicle syndrome by revising every step and trying to make good protocols, select best drugs for the suitable patient, and triggering protocols also is one of the most important issues for prevention of empty follicle syndrome. If you like this lecture, please press on the like icon. If you would like to have more publications, please press on the subscribe and notification icons as well. Thank you very much.